Yeah, we have an announcement. Okay. So, good evening. This is a Bristol Myers Squibb Satellite Symposium, and I have the task to discuss with you how we should think beyond sorafenib and the era of immunotherapy in liver cancer. And let's start by the burden of the disease. This disease, all of a sudden, we discovered that liver cancer is becoming a major threat for the whole universe, but in specific countries, this is much more threatening. You can see it is the second most common cause of cancer-related mortality worldwide. And if you see the incidence in US, France, and Germany, for instance, you can see that the incidence in the range of 5 to 7 per 100,000 per year, which is not heavy, of course. But if you go to the east, especially the far east, you can see the incidence now is very impressive. We are touching the bar of 20 per 100,000 per year. But unfortunately, if you have a further look to what is happening in our country, it is the most frightening ever. It is 43 per 100,000 per year. And for the breakdown, look at the males, it is now 60 per 100,000 per year. And as such, it is probably one of the most, if not the most, high incidence in the whole universe of liver cancers among our males. And the females are not, of course, exempt from that, but it is much less than males. And of course, we are aware that during the last 3 decades, Egypt was the site of the most heavy infection of HCV. We have the highest incidence of HCV across the universe, and the disease is strongly linked to this virus. And if you think how you treat, we've been trying since I was a registrar around 35 years ago, how we treat this disease. And at that time, we thought of chemotherapy like the others. And till we have this very nicely done study coming from the University of China in Hong Kong. And they randomized patients with Child's A into doxorubicin versus an intensified regimen of fluorouracil, interferon, adriamycin, and platinol, a very heavy chemo. Look at the outcome. The response rate is much better or better with the combo, and the survival, median survival is 6 months with Duxu, 8 months with the combo. And look at the mortality. Please look at the mortality in the lower the bar. It is 9% with the heavy chemo, and it is 3% with the doxorubicin monotherapy, by the way. So HCC, later we knew that HCC does not really respond to chemo because of many biological reasons, including very high overexpression of multiple drug-resistant gene. In addition, of course, to the very poor tolerance related to the associated cirrhosis. And outside clinical trials, nobody now actually is prescribing chemo. On the other hand, we in Egypt were a little bit happy about the results of the UFT. It's an oral form of 5-fluorouracil. It's a safe chemo, a friendly chemo. And we used to use this drug because of data coming from Japan to tell us that probably this is one of the most friendly chemo to use in HCC, all phase 2 trials. When we start to know about what's happening on the molecular base of HCC, we discovered that HCC is a very complex disease when it comes to oncogenesis. Actually, one of the most complicated disease when it comes to its molecular pathogenesis. And for many reasons, including hepatitis, of course, and alcohol consumption, these agents are able to induce tissue damage, extensive tissue damage within the liver, which will induce cirrhosis. And with extensive chronic hepatitis and tissue destruction, we have the so-called regenerative nodules which are composed of phenotypically altered hepatocytes. Now, because of the extensive proliferation within the remaining hepatocytes, we have dysplastic changes within the hepatocytes with genomic instability that when it goes further, it will go to marked genomic instability, gene mutations, and evolution of liver cancer. In short, it all starts with the chronic hepatocytic cell injury by hepatitis viruses or alcohol. This will lead to cell death, fibrosis, which is known as cirrhosis, with liberation of extensive amount of growth factors within the liver. These growth factors will bring the remaining liver tissue into a status of chronic cellular regenerative process with hyperproliferation, accumulation of genetic mutations, and by the end of the day, you have either activation of mitogen growth factor stimulating oncogenes or inhibition of tumor suppressor genes. Angiogenesis is very crucial in liver cancer, and we know that liver cancer is extensively angiogenetic, and we knew a lot about the role of vascular endothelial growth factor receptor and the growth factor itself in the evolution and progression of liver cancer. If you go to the genetic map in liver cancer, you'll be frustrated. You'll find, of course, angiogenesis, vascular endothelial growth factor receptor, or platelet growth factor receptor. But you will find a lot of other players, so much that actually you have many growth factor receptor activation, but unlike disease like melanoma, like lung cancer, you don't have a driver mutation. And because you don't have a driver mutation, none of the target therapies is actually targeting the real player in the development. However, we knew more than a decade ago that BRAF, the RAF protein overexpression is present in almost 100% of HCC. And this RAF signaling pathway, it is the RAS, RAF, MEK, and ERK, it will end up by proliferation and angiogenesis. If it is overstimulated, the RAF is what we call constitutively activating signaling into the hepatocyte, inducing liver cancer, inducing angiogenesis, and then why not to target the RAF? And that's why a drug like sorafenib was developed, because it's an anti-RAF kinase, and in the preclinical model we have seen that this drug in a dose-dependent manner can induce regression of liver cell cancer. If you take this data, go to the clinic, you will find the two pivotal trials, one from the West, one from the East, and they both told us that if you compare in the first-line setting sorafenib against placebo, it's not an active treatment against placebo, you improve significantly. By statistics, yes, of course, you improve significantly the disease-free survival and overall survival, but look at the absolute benefit. The absolute benefit in either trial does not increase the overall survival beyond 3 months compared to placebo. And if you see the response rate, it is pretty low. The overall response rate is in the range of 2 to 3%, very low, and the last column the last bar is very frightening, because this treatment was not able to stop the symptomatic progression. That's to say, your patient will not have a symptomatic relief of his disease. And we have a lot of side effects. The side effects, by training, you can know how you can deal with these side effects, but it exists. Usually it is grade 2 to 3, usually, and the practicing oncologists now, especially in Egypt, we are pretty aware how we can deal with this portfolio of side effects. In the real-life data, the Godwin trial told us that don't try this drug when your patient has Child's B or C. Look at Child's B. The overall survival with this drug is less than 5 months. Child C, it is 2 months. And put your money on patients with Child's A, because other than this, the patient will die anyway. If you try to improve over sorafenib by more anti-angiogenic drugs like sunitinib, for instance, sorafenib was significantly better. Other drugs, less famous tyrosine kinase inhibitors like birafenib and linifanib, they did not get any benefit beyond sorafenib. Sorafenib stood the test of time. However, recently we have the lenvatinib. The lenvatinib is approved for medullary carcinoma of the for undifferentiated carcinoma of the thyroid, well-differentiated carcinoma of the thyroid, and for RCC. And when it was compared against sorafenib, you can see the overall survival is again the same like sorafenib. But for the first time, we could have a drug that has a response rate better than sorafenib and time to progression longer than sorafenib significantly. However, again, look at the toxicity. Grade 3 and 4 toxicities were encountered in around 55% plus, and the drug is still, the approval is not granted by the FDA. How to improve over? Why not to combine sorafenib with another drug? We have several trials to do this. One with erlotinib was negative against sorafenib alone. One, sorafenib plus doxorubicin against sorafenib alone. Again, it was negative. And we have our trial, the Egyptian Liver Cancer Society trial, which we compared sorafenib plus uracil UFT versus sorafenib alone. And this was the design of the study. It was a phase 2 study. The majority HCV positive, of course. The majority were Child's A. And look at the response rate. The combo was not better. And more importantly, progression-free survival was the same. Overall survival was the same, although it tended to be better in sorafenib. The quality of life lowered while you give this treatment, while the symptomatic score increased, which means that your patient's symptoms are increasing by time. So we have a lot of unmet needs with what we have in hand. We have multiple pathways involved in the evolution of liver cancer, but we don't have what we call driver mutation. So we are not like in the case of lung cancer, for instance, like EGFR mutant disease. The targeting RAF kinase by sorafenib is still the standard of care. It's the only approved treatment. However, the gain, as we have seen in overall survival, is mild, and the response rates are very low, and we have a lot of side effects. The quality of life is not maintained. So that's why we have to think beyond the sorafenib, and novel therapeutic approaches are certainly needed. And if you see the immunological profile of liver cancer, you will soon know why we think about immune therapy in liver cancer. Just to remind you, for the idea of immune therapy, you know, cancer cells, they have plenty of mutations, and these mutations will be manifested as new antigens, which are seen by the immune system, which will activate the immune system. When the immune system is activated, we have the generation of the tumor-infiltrating lymphocytes, which will induce something called the T-cell inflamed tumor microenvironment. The tumor microenvironment now is full of immune cells. These immune cells can attack the cancer cells, and they can eradicate some of these cancer cells. And if you want to see proof of concept of that, this trial coming from breast cancer, you can see tumors with low tumor-infiltrating lymphocytes, they have the poorest prognosis, while tumors with high tumor-infiltrating lymphocytes, they have the best prognosis. And across the board, we have seen that in many tumors. If you have high tumor-infiltrating lymphocytes, the prognosis is better. However, the tumor-infiltrating lymphocytes are not one single entity. We have plenty of the components of tumor-infiltrating lymphocytes. Some of them is very useful, and they can really attack the cancer cells and eradicate the cancer cells. Top of the list is this cell, the T effector cell, the cytotoxic T cell, this one. And the cytotoxic natural killer, again, they can eradicate the cancer cells. But some tumor-infiltrating lymphocytes, they are actually working in favor of cancer progression. They can induce cancer progression, and the most important one, of course, for us is T regulatory cells and myeloid-derived suppressor cells and macrophage type 2. So, if you go to this beautiful trial in liver cancer, you will see that if the T regulatory cells, which are bad cells, if they are low, now the prognosis is good. If they are high in blue, the prognosis is poor. While on the other hand, if the good cells, like the cytotoxic T cells, if they are high, the prognosis is better. If they are low, the prognosis is poorer. And of course, the best scenario, if your patient has low T regulatory cells and high cytotoxic T cells, now the prognosis is the best, and vice versa. So it's very important to recognize that we have prognostic role of tumor-infiltrating lymphocytes in liver cancer. If the cytotoxic T cells are high, you're in a better position. If the Tregs are high, now the prognosis is poor. So importantly, if you wish to manipulate the immune cells within the liver cancer, you think how you can increase the efficacy of cytotoxic T cells or how you can deplete the T regulatory cells. So the first take-home message is very clear. Tumor-infiltrating lymphocytes, they are part of the cancer process. They are recruited into the tumor microenvironment in attempt to control the growth. However, not all the components will play well with me. Some cells are very efficient in eradicating the cancer. They are basically the cytotoxic T cells, while other cells, which I call bad cells, they can stimulate the tumor progression. So it is the quantity and the quality of the tumor-infiltrating lymphocytes that will give rise to immune response. Importantly, the cancer cells, they can break the anti-cancer immune response by activation of the so-called immune inhibitory pathways, which now we call immune checkpoints. The immune checkpoints are very much needed in our bodies physiologically. If I have an antigen in my body, my T cells will try to get rid of this antigen, but actually, after eradication of the antigen, the T cells should be shut down. Otherwise, everybody will develop autoimmune disease. So in order to downregulate the immune activation, we have the so-called immune checkpoints. We have many immune checkpoints. The most known to us are the CTL4 and PD-1. And for the sake of time, I will only try to cover the PD-1 because it's very relevant in liver cancer. The PD-1 is a programmed cell death receptor. As the name implies, if this receptor is expressed over the surface of the T cells, and if it is activated by its ligand, which is PD-L1, now the T cell will be suppressed. This will happen at the level of the tissues, including the tumor microenvironment. Importantly, in liver cancer, if you wish to know why HCV is really chronic, it is chronic because of the long-standing of PD-1, PD-L1 happening in the liver. So now the immunity against the HCV is suppressed. And it is also responsible for what is happening in cancer. So let's see the sources of PD-L1 in the case of a tumor, where we will have the PD-L1. First of all, we have the PD-L1 physiologically expressed by many immune cells. Some cancers, they have genetic expression of PD-L1, but most important is the PD-1 expression is induced by the gamma interferon secreted by the T cell. This is very important. Let's see how this happens. We call this adaptive immune resistance. If you imagine that's the cancer cells and that's the T cell attacking the cancer cell, this T cell should kill this cancer cell by gamma interferon. But look at what will happen. After a while, the T cell will start to express the PD-1, that's physiological. Importantly, the cancer cell, when it is attacked by the interferon, it will start to upregulate its own PD-L1. Now, with the PD-L1, PD-1 interaction, the T cell is killed. Remember, the T cell was supposed to kill this cancer cell, but now this cancer cell could really kill the attacking T cells. So this will explain how cancer can escape the immune destruction in spite of the presence of immunological reaction. So at the level of the tumor microenvironment, the activated T cells that should kill tumors are specifically disabled through the PD-1, PD-L1 pathway. And in preclinical models, we have seen that if you block this pathway, you can restore, please remember, restore the T cell function that can eradicate the cancer. And clinically, at the present time, we have approvals in more than 10 types of cancers of drugs targeting PD-1 and PD-L1. Why liver cancer we think of immune therapy? Because liver cancer is unique. The liver immune microenvironment is unique. Our surgeons in this room will tell you, when you transplant the liver, the rate of rejection, the chronic rejection, is the lowest compared to kidney transplantation or heart transplantation. It's very low in the liver. Why is that? Because the liver T cells, actually, the T cells, when it goes into the liver, they will be immune suppressed. This is very unique. Why is that? Because the liver all the time is exposed to many antigens coming from the flora in the intestine. So all the time, the T cells within the liver parenchyma, they have upregulation of the PD-1, while the hepatocytes and Kupffer cells, they express PD-L1. That's physiologically. In liver cancer, if you have a look on the in vitro studies, Kupffer cells in liver cancer, they express enormous amounts of PD-L1, and if you block this in vitro, then the liver cancer will regress. In the clinic, we have a beautiful trial, very simple trial, 56 patients with liver cancer, 20 with liver cirrhosis, and 20 healthy controls. If you have a blood sample from them, you will find that the circulating T cells, they are PD-1 positive, that's to say, immune suppressed T cells, they are present basically in patients with liver cancer and compared to healthy controls. And in this liver specimen, the tissue specimen itself, we have drastic increase in PD-1 in the T cells and drastic increase in PD-L1 in the liver cancer cells. And in these patients, if you have increase in PD-L1, the prognosis is poor. That's patients with low PD-L1 in blue, and that's patients with high PD-L1 in red. The prognosis is better if it is low. Furthermore, the HCV will add more T cell suppression because the T cells, which when it is exposed to HCV for a long time, will be actually attacked by the PD-1 expression. And this PD-1 expression will be activated by the Kupffer cells, and through the PD-1, PD-L1 interaction, my body will not be able to face HCV. That's why we develop chronic HCV. Now, if this patient will develop liver cancer, his T cells are already immunosuppressed at the time of liver cancer development. More importantly, for any immune therapy to succeed, you need this liver or any cancer, it should express some tumor-associated antigens. And actually, the liver cancer, it expresses at least 7 well-known tumor-associated antigens. So taking together, and if you look into the rate of spontaneous regression, which means that our bodies are really fighting the liver cancer immunologically, you will find that the liver cancer is one of the highest instances of spontaneous remission. Look at this, the pivotal trials for the placebo, for instance. The placebo, the response rate in the placebo is very close to the response rate of the sorafenib. In the second line, in the placebo arm, the response rate was 4% versus for darugrafenib 11%. So our bodies are inducing spontaneous regression for the liver cancers with no treatment. Furthermore, we have a better survival in liver cancers if we have high cytotoxic T cells. Furthermore, we knew that Kupffer cells and liver cancer cells, they express the PD-L1. Put this data together. Why not to tackle the PD-1, PD-L1 in liver cancer? Let's see the results of the pivotal trial, the nivolumab in liver cancer. This trial was 2 parts. Part 1 was dose escalation to find the safety. It included 3 cohorts of patients with no viral hepatitis, patients with HCV, patients with HBV, and it was important to see that grade 3 and 4 toxicities are quite minimal across plenty of dose levels, and across these dose levels, 3 milligrams per kg was selected for further development in the so-called expansion arm. Now we have more than 260 patients. Let's see the outcome of these patients. Part of them was sorafenib naive, part of them was sorafenib exposed, and the majority, of course, were Barcelona clinic stage 3, and a minority, around 20%, were HCV positive. The sorafenib intolerant or sorafenib exposed patients, they received sorafenib for an average of around 4 months, and the response rate now, we started to see this kind of response rate. In sorafenib naive, we have 20% response rate. We have seen complete remissions. In sorafenib pretreated, we have between 15 to 19%. And the survival for the first time, remember the survival with chemo was 8 months. With sorafenib, it is 10 months in first line. Now you can see in first line, the sorafenib, in the sorafenib naive population, the overall survival median is 2 years plus 28 months, and for pre-treated, it is 15 months. So these data are never precedented. We have never seen this data before. I have my own feeling, my own reasons to believe from this data and from others that this drug will work better in hepatitis C. You can see, to start with, in the hepatitis C population, that's second line, the response rate is 25 plus, while it is less in hepatitis B, and the non-infected, again, the overall survival, the median survival, the overall survival at 1 year was showing a trend to be better in HCV patients. For me, this is the most important slide, which is the quality of life of patients treated by this drug. Look at the quality of life. Over 6 months, the quality of life is maintained. Remember, the quality of life with sorafenib in all the studies was declining over time. Now you are stabilizing the quality of life. That's why we have this trial in process in first line. Now it is phase 3 randomized against the standard of care of sorafenib. Importantly, for the side effects, we need to be aware that we have unique side effects related to the immune-mediated reactions within the bodies, but the grade 3 and 4, for some unknown reason for me, is much lower if your patients have been exposed previously to sorafenib. It is 18%, it's very low, while it is around 29% if it is naive. Part of these side effects are laboratory side effects, actually. Increasing lipases, you have to take care of this. Increasing liver enzymes. In grade 3 and 4, always very low, but it is there. You have to revise